Fowotade, Dr. Adeola Fowotade, you are welcome. And somebody is connecting you. Can you hear me? You can just.
I can hear you. Good afternoon.
Okay, good afternoon. I want to believe it's Major General.
Dr. Musu is on.
Okay. So just.
Thank you very much, Dr. Lawal. Dr. Lawal is the General Secretary of the College of Nigerian Pathologists. I actually want to thank you all very, very much for accepting to give this presentation today. The background, which I'm also going to share when we start, is that it was just a decision to start a series of engagements with pathologists and also with other people, because we find that sometimes even among pathologists, I believe we can do more than we're doing now. And getting the experience, COVID-19 has presented a good opportunity for us to be able to share experiences. At least that's one thing that the whole world is going through. So we wanted to use that as a basis to see how we can develop ourselves. And this would actually be something we intend to continue doing for some time, not only for pathologists, also for other people, for other medical specialties, and even for the community. So we might ask you to come back. And also, I would also ask that if, for instance, you also find that there's something you also think you want to share, we'll be able to provide a platform for you to be able to do so. Each presentation we have put to take about 15 minutes each. If it can be a bit shorter, that would be nice, so that we'll be able to have at least a full 30 minutes for interactions, because I can assure you, even though we ask people to send in, few people sent in their questions, but many people will be ready to interact and based on the presentation and also the experiences that we have on ground. So I thank you all very, very much, and I hope this would be, we actually thought we were only going to take 100 people, but the thing has been extremely, people have been very enthusiastic. So we have about 300 people who actually are going to be listening in today. So I think we have done well as a good start. So thank you very much for accepting. I'm sure the names also caused the enthusiasm that people used to come in. So I think we can start. I'll make a short introduction, and then we'll start with Dr. Oladipo, and then Dr. Rotimi, then Dr. Fowotade, and Dr. Akaba. After that, we'll have the short interactive session. So I hope everybody's mic has been tested and is working. Well, good afternoon, everyone. I am Tilewa Amusu, the College of Nigerian Pathologists. And I'm very happy to welcome everyone to this first webinar, which we are organizing. I think COVID-19 has presented us all an opportunity to know that we can do many things without the physical interaction. And the beauty is that means we can also have a wider spread. This is the first in the series of webinars, web meetings, and other forms of e-engagement that we hope to have for pathologists, for other medical specialties, other health professionals, and also the community. And hopefully we should be able to continue and have at least once every week. So today's webinar is on the roles of pathologists in the COVID-19 era and beyond. And I'm happy that we'll be able to have the opportunity to learn from experiences across 3 continents. So I want to thank our resource persons for accepting to share their experience with us. We have Dr. Jumoke Oladipo, who is calling from the US, Dr. Olondarutimi from the UK. We have Dr. Adeola Fowotade, who will be sharing the Nigerian experience, and Dr. Kingsley Akaba, who would give us a presentation that I'm sure will be beneficial to us all in the COVID era and beyond. So I hope that the outcome of this webinar will be able to help us look again and help us to delineate our job descriptions, to be able to engage the medical community and administrators, as well as I'm hoping to create a niche for pathologists, especially when we look for relevance in the practice in Nigeria. So each presentation will last about 15 minutes. I thank those who have already forwarded questions, and this will be addressed in the course of the seminar. So we'll be starting with Dr. Oladipo, who is an assistant professor in the Department of Pathology and Lab Medicine, and also the medical director of hematology and coagulation. She's an associate director of automated testing lab in the Penn State Milton S. Hershey Medical Center in Pennsylvania, USA. Thank you very much, Dr. Oladipo, for coming, and please we'll be able to start with your presentation.
Right, so I'm going to, sorry, while I'm talking, I'll just mute my video and then I'll put it back on once I'm done. So I'm going to talk about the role of pathologists in the COVID-19 era and beyond, and I'm really going to talk from the clinical pathology point of view because I'm a clinical pathologist. Over here in the US, we have separate AP and CP functions. So I'm really going to talk more about the CP, and then at the end of it, I'm going to try and address the 3 questions that were sent in, even though there were cytology questions, but I was able to ask my cytology colleagues and they were able to give me answers. And another thing is all the experiences I'll be talking about are dealing basically with my own hospital, because even though we have general guidelines, every hospital still has to decide how they're going to go about their processes depending on what they have and their unique situations. So I'm going to start with this diagram, which was actually published online by the International Federation of Clinical Chemistry, looking at what the role of laboratory medicine is in COVID-19. And basically we know now, we all know that it actually has to do with either diagnosis or monitoring. And when we're talking about monitoring, it has to do with either staging, prognostication, or therapeutic monitoring. And basically, the 2 questions that, to the layperson, the 2 questions that we have to answer in the lab is, do I have the disease or did I have the disease? So when it comes to do I have the disease, it has to do with diagnosis. And when it comes to did I have the disease, then that's when we go into the antibody testing and all that. So here at my hospital here, with the beginning of the COVID-19 pandemic, there is a hospital COVID-19 command center, which has representatives from all the departments. And so we have a pathology departmental administrative director that goes to these meetings, which they have daily, and brings back like whatever was discussed, and that is relayed to the department. And at the beginning, sometime in March, all the pathologists were asked to sign a document which just stated more or less that we can be called upon to cover other areas that we usually do not cover but are trained in. So it's more like cross coverage, which is very dependent on what the load of the pandemic is and what is needed at that time by the hospital. So here for diagnosis, we do, we actually have 4 platforms. And one of the things that the pathologist has to do is to really decide what test you want to do and on what platforms you're going to do it based on the analytic performances or analytic characteristics of the test. It was easy for us here because we already had these instruments in-house, and it was just easier for us to look at what the characteristics were and what the turnaround times were and what is involved in the testing before we went ahead and got the reagents for each one of them. Before we were able to bring up our own tests in-house, we had to send this test out either to the state lab or to the reference labs for us to start off. But by then, the turnaround times were much longer, and it was desirable to have a very short turnaround time in-house. So now 85% of our testing is actually done in-house. Another problem that we encountered was that there was a lot of shortage of kits, swab kits from the companies. So we started to prepare our own. So we got swab sticks, and we also got phosphate buffered saline, and we just mobilized our staff in the lab, and we prepared our own kits that we're now using. We also got some kits from the instrument companies, but that is not near what we need to use. And then finally, our engineering department in the university here, which is just on the other side of our building, designed our own 3D swabs, which we had to test and we had to validate in the lab. And once that was done, it has now gone into production. So that is going to be like our backup. And all this was actually supervised by our microbiologists. And the last one is for proficiency testing and for our assays. So we had to decide what proficiency testing we're going to do. And then the other testing that we just started doing, just this Monday, just 2 days ago, was the IgG assay, which is the serology testing for people that have had the infection. And we're also in the process of verifying other assays. All these platforms, the Diasorin XL, the Roche machine, and the Abbott assays, these are all machines that we already have in-house. So we're not putting in extra money into buying new equipment, which is going to take so much time. So, and the lesson here is that whatever we have on ground, we first of all look at those we have on ground and to see what we can do with what we have on ground before going ahead to start getting new instruments. This is an example of what we have to present to the hospital every day. We have to present this dashboard, which is a laboratory dashboard concerning, which has to do with the testing that we do in-house, and the turnaround time, the average turnaround time, and the positive cases. So this is a dashboard that we present for all our in-house testing. We have a separate dashboard that we present for the few tests that go on outside the hospital, but more and more, about 85% of tests is now done in the hospital. So this is what everybody has access to this within the hospital system to be able to follow up. And this is all something that the pathologist has to be in charge of. So I have just put here a summary of what the laboratory director or pathologist has to be in charge of and is responsible for. The pathologist is responsible for the design and the oversight of the validation and verification of all the assays before they are put into use. If the pathologist does not put his or her signature down to say that I have looked at this assay, I have verified that these assays can be used, then that test cannot be used. And the pathologist also has to sign off on the proficiency testing and also work very closely to check all the results every day, and has to know about all the glitches and all the QC issues that are that they have in the lab. And he or she is also responsible for ensuring that all the results are reported to the state. We have a software in which we report all positive and negative results to the states, and this has to be captured by the laboratory information system. The infectious disease clinicians are in very close proximity to us here. They're always here. They're really the ones that work hand in hand with the pathologists to be able to decide who to test and what tests to run on who, since we have different platforms, and also the turnaround time and what the effect that would be on patient care. The pathologist is also responsible for the comments that go with the results, because we don't necessarily see all the results before they go out, but all the results would have to be appended with a particular comment, especially the ones that are being done now, the new antibody testing, based on our own knowledge of what the use of that test is. And we're also involved with staffing issues because we have to optimize the safety of our lab staff. And we also have to sign off on all the standard operating procedures and any changes in policies concerning the changes concerning the pandemic. We're also responsible for education, not just our own staff, but we have to educate other people in the hospital concerning the latest updates. So we have all kinds of meetings and conferences that we have to participate in and let them know what is happening within the pathology department, what the pathology department is actually doing. And if there's any concerns from any one of them, they can reach us, and we also give them our contact information. We're also available for clinical and technical consultation concerning the assays, and we get a lot of those questions from clinicians. The other aspect that pathologists are very much involved in are when it comes to the production of convalescent plasma. We do not produce it here, even though we're part of a study protocol. But the pathologist has to give the go-ahead and also has to arrange for the convalescent plasma to be provided to the patient after the patient has been cleared to have the convalescent plasma. This is done by our blood bank directors. So the other roles that we have in the hospital, we have a part of pathology which is called the experimental pathology part, which are really involved in research, and that's basically all they do. And they also, and we also have to develop and update all our protocols in our respective subspecialties concerning the current guidelines, looking at what our situations are. And we're responsible for other testing oversight, which is not limited to COVID-19 patients, but are used in COVID-19 patients for prognostic purposes. And this is just a list of some of the testing that are done and what is expected in COVID-19 patients. All this testing is actually done in-house, and we don't really, since our turnaround time is the same for COVID-19 or no COVID-19, we don't really have a special route that this testing has to go to before it goes out to the patients. At the national level, the go-to resource site for all of us is the College of American Pathologists website, and they would also refer to either the CDC or the FDA website too, but they are the ones that give the guidelines on implementation and use of the testing, and they have developed proficiency testing program already for the COVID-19, both molecular and serologic tests. And also the other thing that they did at the national level was to allow pathologists get money, that's those that are in private practice, to be able to get part of the payout from the government to cover their expenses during the pandemic. And they've also allowed remote sign-out of pathology cases, especially in the era of HIPAA, where you have to be very careful with patient information. So but this is just for the period of the pandemic. Everything will revert back once the CMS have decided that it's time to go back to normal. Pathologists are also very active in other groups, and they hold leadership roles in these groups, and therefore at the end of the day, pathologists are the ones that actually make a lot of contributions to all these groups that I've listed here, and they all have their guidelines that that help to guide testing in different areas. So in summary, laboratory measurements are essential not only in the diagnosis of COVID-19, but also in risk evaluation, in patient monitoring, and also epidemiological studies. And the pathologist has a very vital role to play in test implementation, test interpretation, and also in management of COVID-19 patients. And as we have learned from different resources, that many abnormal lab values are associated with poor prognosis, and so we need to be able to give them these values on time so that they can take the appropriate actions on these patients. I don't know if I should go through this question. These were the questions that were sent in before the seminar took place, because we asked people to send in questions. We had 3 questions, and they're basically just cytology questions. I'll just quickly go through those questions, and you would have access to the slides to be able to look at this at a later date. The first question was that what modifications are required in the standard protocol for fine needle aspiration biopsy to prevent spread of COVID-19. And all the recommendations I have put down here on this slide are the ones that we do in this hospital. Every hospital has their different protocols depending on what they have available in their system. But we basically still follow the CAP and the CDC guidelines. But for now, we do not do FNAs on patients with known COVID-19 patients. And all rapid on-site FNA review on lung biopsies are suspended for now. And these are done exclusively by core needle biopsy. And the other things that we've put in place is that we have created teams so that staff are staggered and you don't have everybody in-house at the same time, just to be able to, for their own safety. The second question is that in handling gynecological smears for liquid-based cytology, how should the standard protocol be modified? We do liquid-based for all cases, and we usually would open them and do everything under a hood. We have level 2 and level 3 BSLs that we use here, and our staff would use N95 masks to process specimens. The third question that came in was that, can cytology help in the diagnosis of COVID-19? And what are the diagnostic clues and criteria in a suspicious cytologic smear? And the simple answer to that is that we cannot diagnose COVID-19 on smears, but we can rule in other pathogens that the patient may have as a co-infection. And there are very non-specific changes that occur. Everything we do, really, we follow the CAP guidelines and also the CDC guidelines, and I've put the websites there. So with that, we'll take more questions at the end of the talk, and that's the end of my own aspect. And I will take any questions much later. And this is just an area view of my hospital here and the medical school. And it's at Hershey. If you like chocolates, that's the sweetest place on earth. Thank you very much.
Thank you very much, Dr. Oladipo. Thank you very much for the presentation, and I think it's touched on the areas that would benefit us. So I would like to call Dr. Olorunda Rotimi, who is going to give us the second presentation. Dr. Rotimi is a consultant histopathologist. He is the Clinical Director of Pathology Clinical Service Unit, the Leeds Teaching Hospital NHS Trust, Leeds, United Kingdom. So he's going to be talking to us too from the UK view, or the Leeds experience, as Scotty. Thank you very much, Dr. Rotimi.
Thank you very much for the invitation. And I will try not to repeat what the first speaker said. Actually, I want to approach this more from a leadership point of view and how a service should respond to a pandemic and pathology as in particular. As a background, Leeds Teaching Hospital is one of the largest hospital trusts in the UK. It's a reference center for many of the services, and pathology here is also one of the biggest. Just to give an idea of the size and the services, Leeds has 18,000 staff. That is all staff. And pathology as a whole, we have 750 staff. Operationally, the hospital has what you call clinical service units or support units, and there are 19 of those. So pathology is one. We have 6 departments. So it is a big setup, and it was a big challenge when the pandemic ball was rolling down the UK side to see how do we respond to this. And similar to what Dr. Bimbala, I think, had said, we also had kind of a command structure in the response to the pandemic in the hospital. We have a gold commander, silver command, and bronze command. And being clinical director for pathology, I was therefore the bronze commander for pathology, but I have other people I work with. So that's as a background. And when the whole thing came, the outline I wanted to use is how do we respond to it? So we did 4 main things. The first is to identify areas of the service that will have a direct impact of the pandemic, and then along with that is to plan for emergency response in the other areas of the services. And then as we settled down, then we looked into outline a business continuity plan across the services, and then plan for a recovery phase. We are in the recovery phase now. And identifying the services with direct impact in pathology. There are 2 main ones. It's the virology service, which deals with the diagnosis and therefore the testing. And I think a lot has been said about that. We have 8 platforms for the diagnosis in Leeds, and that quickly raised the problem of staffing needs, because before the pandemic, we had a relatively small virology team of about 7 staff doing less than 100 samples a day. So even a week actually, but with the pandemic and with the projections, we were looking at to do tests of over 300 a day, and currently we do about 500 a day, but we have capacity now for about 2,000 tests a day on all the platforms. So, and also we extended the service to beyond normal hours, and therefore which meant you need more staff. So quickly we had to face with the staffing needs, and therefore we asked for redeployment of staff from other parts of pathology and also universities, so those who have molecular knowledge, and then just train them on the platforms. And of course, this issue of equipment. We initially started with 2 platforms. We had 5 platforms, but we only had reagent for 2. But over time, we've got the reagent for the other ones, and also the supply of reagent. That in the UK was centrally managed, so it took that pressure off hospitals needing to look for reagent themselves. The Public Health England managed that, and they were allocating reagent based on what platform you have in your hospital. So that was the direct impact for us in virology. And of course, the other side is mortuary services, as knowing what has happened in other parts, that the disease was quite fatal and still fatal in the elderly. So we quickly had to assess our capacity, and within weeks, moved from 206 mortuary capacity to 460 by having some more rooms turned into mortuary spaces with refrigeration. But of course, when you increase capacity, you also need more staffing, and that also brought a challenge. But at the same time as the pandemic was taking off, surgical specimens in histopathology were going down. So it was easy to move staff from histopathology lab to mortuary, and so we had teams working in the mortuary. Leeds has 2 main teaching hospital sites, so everything had to be doubled up, and also transportation. So that was on the direct service side. I'm not going to read all of this, just to give an idea of how you approach a pandemic. So on the phase 1 was the emergency response. And so myself and the senior management team, so the structure is that you have a clinical director, you have a general manager, and you have a head of profession in pathology or the chief matron in clinical unit. So we form what you call a TRI in Leeds. So the TRI, and we run the CSU. So we set out all these questions to the various services, and each service is run by a clinical lead, or what you would know as head of department in Nigeria, and a service manager, and then operational leads for the various things they do. So we set out these questions. What are your essential services that we need to continue? Like transplant biopsies in histology or blood samples or blood tests in blood sciences. The services that you can stop now, so esoteric tests or seminology in histopathology, we stop that immediately. Our services that you can reduce or you stop soon. And then what stuff can you release? Because based on those 2 questions of what you're stopping doing, then you will have staff capacity and the release of those staff to do other things in other areas like the virology I've talked about, or in the mortuary. And then what equipment do you need? Because with COVID came the issue of social distancing and then having to work from home, and therefore a huge need for laptops and remote access. And how do we communicate? Then in phase 2, after we finished with that and we saw what we were dealing with and what we were running, we did the business continuity arrangement to say, okay, what staff do you need now to work, and how many people are working from home, and what arrangements have you put in place to maintain social distancing, but at the same time still do the job. And lastly, now we're in the recovery phase, because now in the UK, the infection rate has gone down significantly. Everything is going down in the UK now, the death rate, the ICU admissions. So the hospital now is in the recovery phase, but it's a different recovery phase, because it's a recovery phase that is defined by your COVID status as a patient. Are you COVID positive, you go into the hot ward, or COVID negative, and also the staff. So we've had to do a lot of staff testing to know what's the prevalence among staff, and a few asymptomatic staff are positive. And so now the key question now is, how can we maintain social distancing as activities start to increase? How will you manage your service given that some of staff are already being redeployed, and that's an issue I've had to deal with today. And some staff that have already deployed don't want to go back to the primary department. That's another challenge in that. Then we also ask all the services, what recruitment do you need to consider now in the light of new way of working? And us in the UK, almost 2 million people are in what we call shielding categories, so those who are vulnerable, diabetes, or have chronic conditions, including staff, and some of those. So we're asking what impact is that on the service, and what can they do while they're at home, and of course, what's the new technology? Because now, yeah, I'm talking to you now from the UK, same way we're using Zoom and Teams for all of our meetings now. So, which also meant everybody needs to have a webcam or headset on their computer to do that from their offices to maintain social distancing, and also new technology. So just as a quick summary, is the way we've approached and respond to the pandemic here in Leeds, and hopefully take some more questions at the end. And for those who may be interested, I present some papers on cytology, because which supplements the answers that have been given for those.
Very much, Dr. Rotimi. And I also want to thank both our first speakers for making good time. We are now going to ask Dr. Deola Fawotade, who is doing a lot of work in Ibadan. I know she's quite busy. We've all been having to refer to her for one thing or the other. Dr. Fawotade is a clinical virologist at the University College Hospital, Ibadan. She's also a senior lecturer, the clinical virology unit of medical microbiology and parasitology department in the College of Medicine, University of Ibadan. So she's now going to tell us what she's been doing. That's the Nigerian virologist point of view on what pathologists should be doing. Thank you very much, Dr. Fawotade.
Thank you, Mark. Good afternoon, senior colleagues and colleagues. It's good to be here. In the next few minutes, I'm going to take us through slides that center on the role of the Nigerian pathologist in the COVID-19 response. And I might be a bit biased towards my subspecialization because I'm a clinical virologist, and that is what I do, and that's what I've been doing. So essentially, just to say that the entire world at the moment is plagued by the SARS-CoV-2 virus, which is responsible for the current pandemic that we have ongoing at the moment. And it looks like there's no perfect size that fits all at the moment, as everyone has been trying to deploy whatever tool that they are able to lay their hands on. And we're not really sure which one is even the best of all the tools that we have so far. In Nigeria, at the moment, we've been able to test about 65,885 samples, and this reflects that we are still grossly under testing because what we've tested so far is only about 2.5% of the entire population of over 2 million. And so in all, we've been able to confirm about 10,819 cases with 314 deaths so far, giving a case fatality rate of 2.9%. And so when I wanted to do this, I thought about what exactly, or who is a pathologist? And I found this definition from Johns Hopkins University, which says that a pathologist is a medical healthcare provider who examines bodies and body tissues. He or she is also responsible for performing lab tests, helps other healthcare providers to reach diagnosis, and is also an important member of the treatment team. And this essentially summarizes what we have been doing as pathologists in Nigeria since the COVID-19 outbreak. And I've stratified our level of involvement to the pre-COVID, intra, and post. Pre-COVID, it means pre-COVID-19, before we had our index case in Nigeria. And I would say that even before that happened, as far back as early February, between February 17 to 20, I was invited by the Nigerian Center for Disease Control to be part of a workshop for development of guidelines for COVID-19 case management. And I particularly led out a sub-team that dealt with development of guidelines for sample collection, transport, sample collection, packaging, and transport. And I was also part of a subcommittee that developed the case management strategies, which is what we are using currently in Nigeria. Again, as part of an infection control committee, we had to increase the level of awareness on hand hygiene, remind people about the 5 moments of hand hygiene, and this we did as a department of medical microbiology and parasitology at the University College Hospital in Ibadan. And to also be able to sensitize the members of the hospital community, we also had like a hospital-wide grand round where we had myself and our high physicians talk about how to recognize symptoms of COVID-19 and to also encourage appropriate health-seeking behavior among staff. And because we had an existing hospital outbreak response team, which was carved out of the Infection Control Committee, all we needed to do in response to preparation for the COVID-19 was just to set up a COVID-19 task force committee for the hospital. And this is being led by a pathologist. And essentially the roles of the committee is to assign different roles in the response to different members of the committee and ensure that we ensure that every member of staff of the hospital is brought up to date with what to do to protect themselves from getting infected, and to also make available the necessary personal protective equipment, and the committee reports to directly to the management. And this has helped in ensuring some level of safety in our hospital. This is showing the workshop that I was referring to, and what we have here is the document that serves as a guideline that we have currently for COVID-19 case management in Nigeria. And I also know that some colleagues of mine, pathologists, microbiologists, have also been involved in developing the guidelines for infection prevention and control as it relates to COVID-19. So intra-COVID, my role evolved from being called upon to come and collect samples for our index case in Oyo State. And then subsequently, the state wanted to set up its own COVID-19 task force. And I was an inaugural member of that committee. And then later on, when we set up our state emergency operations center, I was also a member of the EOC. And then subsequently, I evolved to become the laboratory pillar lead for the Oyo State Emergency Operations Center. And my role as a laboratory pillar lead was to develop our own Oyo State SOPs for sample collection and transport, and also to coordinate with the surveillance pillar to identify suspect cases and contacts of such cases and decide who do we need to collect samples from, when do we need to collect the samples, and who should go to collect such samples. Again, to expand the team, I was involved in training of laboratory personnel, which included resident doctors and medical laboratory scientists on infection prevention and control practices, laboratory biosafety, and how to safely collect and transport samples from suspect cases to the laboratory. And then I'm also involved in the preparation of daily logs of samples collected, cumulative samples that need to be collected, and also to follow up results from the laboratory and ensure that the results are fed back to the surveillance team, who then disseminate to the states and also to the clients. And then again, we are also involved in daily presentation to the Emergency Operations Center on specimen collection processes, number of samples that have been collected, numbers that are outstanding, and also to update the EOC on availability of collection kits. And then as we begin to run out of collection kits, it was also the responsibility of the laboratory pillar to ensure that we find our own way of improvising collection kits. And so we had to buy swab sticks, ensure that they are the right size for the different specific tests that we needed to do, and also to make our own viral transport medium when we fell short of the supplies that we got from the Nigerian Center for Disease Control. Again, it's my responsibility to develop the weekly laboratory incident action plan, which is meant to be presented on a weekly basis to the incident manager of the EOC, and also to submit weekly reports of our activities to the incident manager. Still, during the COVID-19 era, what we are still doing, I'm a part of the state case management team, and some other pathologists are also involved and doing the same thing as I am doing. Some are involved in dignified management of the dead, while some are part of the case management team, and we all work as a team alongside with our infectious disease physicians. Essentially, we are consulted to see the patient at the treatment centers. We're also involved with patient follow-up for sample collection, and then we're also part of development of the post-discharge plan, and we're also part of the membership of the post-discharge visitation team that is meant to visit the homes of the discharged patients to ensure that they are fine. And then again, as a virologist, I'm also involved with development of the admission criteria, because it got to a point when we couldn't start to bring in all positive cases, and we needed to sit down and decide what are the criteria that we want to adopt to ensure that we know those ones that would qualify for home-based care. And this essentially detailed on trying to find out what is the CT value, which is an index of the viral load that these patients had. And for those ones that have specific cutoff viral load and also have a kind of level of literacy to be able to adhere to IPC practices, and who also happen to live in environments where they could properly self-isolate. For those ones, we develop home-based care protocols for them, put them through, and then made them to stay at home. We're also involved in following them up and ensuring that they are fine, so that at any point if they become sick, we move them into the facility. Again, we are involved in weekly seminars at the treatment centers on different aspects of COVID-19 management, including patient placement, IPC practices, and then to update the knowledge of the staff on the various reviews in their treatment strategies that they need to adopt. This is a picture of myself and our infectious disease physician at one of our treatment center, the Agbami Chest Clinic, and a picture of myself and some other members of the case management team at our infectious disease treatment center at Olodo in Ibadan. Again, because we found that we were grossly under-testing, Oyo State is a very large population. UCH by itself is a very large community, and we could not continue to depend on the only NCDC accredited laboratory that we had in the state. So we had to set up our own diagnostic facility, which currently caters for patients of UCH and some other patients within the Oyo State community. And at present, we have facilities for serology and molecular tests. This was a laboratory that was not in existence prior to the COVID-19 era. And so it took the intervention of the provost of the College of Medicine and the College of Medicine, University of Ibadan alumni, who put together the funds to be able to set up this laboratory, which is currently serving this purpose. And at the moment, the laboratory is involved with testing and follow-up of patients and staff at the University College Hospital. And this has really helped significantly because that has helped to reduce the short turnaround time for our results. Before we had this laboratory, even for patients that are on admission or patients that were billed for elective surgery, they needed to wait for days to be able to get into the state testing protocol. But with our home facility, domiciled in the College of Medicine of the University of Ibadan, this reduced the turnaround time and we could accommodate more patients that needed to get tested or more suspect cases, even including our staff. And the facility is involved in research collaborations, both locally and abroad. And we have a number of multidisciplinary grant applications that have been submitted, which we hope is going to expand the frontiers of the laboratory. Additionally, the lab has provided an opportunity to be able to train, to give trainee pathologists an opportunity to have hands-on experience with COVID-19 diagnosis and laboratory management, as a number of them are involved in the laboratory and are also part of the entire process of screening, sample collection down to laboratory diagnosis. We've also been able to have external quality assurance because we have an affiliation with the African Center for Excellence in Genomic and Infectious Diseases at Redeemer University in Hede. And we have this affiliation that allows us to be able to do our sequencing at these facilities for the positive samples that we have accumulated so far. Again, we also started an external quality assurance with the 54 Gene Lab. And we are involved in the process of sending samples between the two labs to ensure that we upgrade our laboratory protocol and improve our work processes. This is a picture of the lab at the College of Medicine, and it's called the Biorepository and Clinical Virology Laboratory. And this picture is showing some resident doctors that were involved in the initial training that we had, which was done by the Inkaba Biotechnology. And this is a picture of a resident and a lab scientist working in the lab. And here we also have a visit to the laboratory by the Director General of the Nigerian Center for Disease Control and the WHO country rep sometime in March this year. Again, we've been involved with a lot of training, and not too far off, we were involved in the training of healthcare workers within the southwest zone of Nigeria on infection prevention and control practices. And we've also been involved with public enlightenment, which has happened in form of television jingles that are heard on television, radio, and as well as newspaper publications. We've been involved in seminars online and offline, and we've also been involved in training of journalists on concise and accurate reporting of COVID-19 related news. And we are currently also involved in a number of research to be able to answer some bits of the questions that are still evolving about the COVID-19 virus. And this slide is showing some of the trainings that I've described on seminars for the Nigerian Medical Association, training of doctors on how to collect samples. And then this is also a picture of our training at this Southwest Zone for healthcare personnel. All right, so post-COVID, beyond COVID, what do we expect that pathologists should be involved in? Surveillance, yes, and then disseminating the output of the research that we have conducted during the intra-COVID era, ensuring that we maintain and sustain IPC practices to a level that would at least delay the onset of the next epidemic. And then it's still very important that we prepare ourselves for the next outbreak, because there's no gainsaying. There will definitely be some other outbreak in not too far off. And like this anesthetist said here, we need to get it into our heads that with COVID-19, our lives have changed and we need to be ready for the next phase of our existence. What are the challenges that we have faced? Top on the list is territorialism. I mean, we have some people that believe that this stuff of virology specifically belongs to them, or some people that believe that laboratory science is for some exclusive preserve and is not a place where you expect medically qualified persons to exist. And this has been a major challenge. And then there's a lot of politics at the level of the government, federal government, state government, that has been interfering with even the COVID-19 response by itself. And you'll also be surprised that even the Nigerian Center for Disease Control sometimes plays some politics that do not allow pathologists to be able to exert themselves appropriately as they ought to. And significantly, in Nigeria, there's still poor recognition of pathologists, even for the validation of the test kits. It was interesting to hear Dr. Ladipo talk about the role pathologists play in validation of their kits and other test processes. But for Nigeria, this is being handled essentially by the Medical Lab Science Council of Nigeria. And even now for the gene experts that is being introduced, this is also still meant to be handled by this group, and this does not augur well for a country that has this number of pathologists. And then again, we have a poor representation of pathologists in relevant organizations like the Nigerian Center for Disease Control, the World Health Organization, and the Federal Ministry of Health. And this has not helped us to be able to perform our roles as optimally as one would have anticipated. In conclusion, pathologists have a role to play in the COVID-19 response, and this spans from diagnostic support to training, case management, education and public enlightenment, surveillance, and research. However, there are a lot of limiting challenges that we have in a setting like Nigeria, where people's roles and boundaries are not properly defined. However, we've learned to be able to manage our successes and limit our failures. And we hope that we'll be able to do more than we are currently doing at the moment. Thank you very much for your attention.
Thank you very much, Dr. Fawatade. You actually have been able to give us a very full perspective as well of what is happening in Nigeria. And it's gratifying to know that pathologists, at least with the challenges we're having, are still able to prove their mettle when it comes to playing our roles in the pandemic. The last presentation this evening would be by Dr. Kingsley Akaba. It's also related to the pandemic, and also like was also said in the description for this webinar, also to look at how we can actually carve out a niche for what we are doing in view of the environment in which we find ourselves in Nigeria. Dr. Akaba is a consultant hematologist, but in addition to his FMC path, he also has a lot of certifications in quality control, a lot of ISO certifications. He's certified in ISO 1, he's a certified internal auditor for the 15189, and also a lead assessor in ISO 17025. He is a consultant hematologist at the University of Calabar Teaching Hospital. So he will be giving us a presentation as well. And after that, we'll be able to look at everything and discuss. But please, I want to remind us that you can please send in your questions to the Q&A box so that some of them are already been addressed.
Okay, I said good evening, my teachers, my trainers, my senior colleagues and colleagues. I'll be speaking from the perspective of quality management in terms of laboratory management, the role of pathologists in laboratory management. I'm very, very happy that Dr. Ladipo pointed out some points, and Dr. Rotibi also brought out some valid points I wanted talking about. It's we as pathologists in Nigeria, we know we have some challenges. If we try to quality assure the topic, we know we have challenges, and if we don't deal with these challenges, we cannot transform our practices. And what are these challenges? Some of these challenges are capacity. In terms of capacity, Dr. Fowotade made mention that we have the numbers. Yes, that's true, but we've been able to utilize the numbers in terms of quality management system, quality practice to meet with other developed clients where precision medicine has taken over. We should now start thinking about capacity in terms of advocacy, policy making, and also building competency. Also, the next challenge is culture. When we talk about culture, in this part of the world, Africa as a whole, or developing nations, we've never embraced quality management in terms of our practice. Most times we just talk about quality control, which is just an integral part of quality management. Dr. Oladipo made mention of proficiency testing. How many of us could bring a document showing talking about our proficiency testing that has been done in our centers or competency assessment programs? I don't think most centers have that. The next challenge is also the attitude. How do we embrace attitude towards this quality management system? This attitude does not just lie in only the pathologists. It also involves our management staffs, our hospitals where we work. We must go back trying to sell this idea. Let the management, the CMDs, the directors, let them also come into it and see that for us to get this practice well, for us to do the right thing, we need to implement quality management in our practice. The next challenge is the friction and risks. The friction and risk aspect of it is what Dr. Fowotade has made mention of, talking about professional rivalry and all those other things like that. I think without the world as a whole has gone beyond that. We can always carry them along. All we need is just to show them the competency level that we are not fighting them, or we don't have any bias against their profession, but all we want is the betterment of our patients. And if we show them the leadership rule, which comes in terms of quality management, both managerial leadership rule and technical leadership rule, this will enhance our service and also make us very good in our practice and also betterment of our patients. The pandemic, COVID pandemic, has also really brought a lot of flaws to the world for us to see, especially in the advent of this pandemic, where you see health workers getting infected, majorly, most of them are laboratory workers because they were just recruited, because the culture and the attitude to competency assessment and proficiency testing, which was not done, which has never been a practice and part of us, had never been inculcated in them. So they've just been introduced, so they just do the routine thing, not knowing that this virus it's very, very aggressive and contagious. Next, we will look at the benefits of quality management system to the pathologists and to the laboratory as a whole. If we look at the benefit, it provides a lot of structural management system, good governance, reliable results, risk management, enhances competency, and also enhances client satisfaction, and also promote standardization for us to be able to meet up with other clients. The essence of this presentation is for us to take home efficiency and efficacy laboratory practice in the era of this pandemic, because this pandemic is not going to leave very soon. It's going to be with us. And if we don't change our practice or improve in our practice, we'll still have the event of people coming down with infections, with this infection, and maybe a second spike, which might be more affecting more of the health workers in our environment. So I think we need to incorporate. Hello?
Dr. Kama, your slides, please. You're not sharing your screen.
Okay.
Okay, please go on.
Dr. Akaba needs to unmute himself.
Dr. Akaba, please go on.
Moderator, the host here cannot do anything about Dr. Akaba, so I just suggest that we can move on with the Q&A session.
Yes, okay.
Dr. Akaba can try to maybe log out and log in again, maybe to establish. Thank you.
Okay, yeah, that's fine. Okay, so we do apologize for that that glitch. Hopefully Dr. Akaba will be able to get things done later. But maybe some people have already posted questions in the Q&A and they have been addressed. But we probably would, maybe if we have some strong questions that have not yet been addressed, some of them probably would not be for this. Now, there is a question here that what is your experience? That would be for Dr. Oladipo and Dr. Rotimi. Your experience with the serology-based assay methods in terms of real-time performance characteristics.
Well, so I'll talk from our own experience here. So I said the FDA here has a list of tests that have been approved, and we do not go outside the FDA. So we look at those tests and we look at what platforms that we have in-house and look at the analytical characteristics. We look at the sensitivity of the test. We look at the target glycoproteins. We look at the limit of sensitivity of this test. We look at the cutoff values and the turnaround times. And these are the things that we look at to be able to decide that we want to go with this test or with that test. And for the serology testing, the timing of the testing is very, very important, because if you do the testing after 2 weeks of infection, you are likely going to get a positive result. Actually, all the antibody tests in the market right now are all qualitative tests. And there are still a lot of questions concerning serology testing. The clinical utility is not very clear-cut because we do not know if at what level those antibodies are neutralizing or not. And it's more for epidemiological studies because, as I said, you're trying to find out, do I have the disease or did I have the disease? So the serology testing is more of, did I have the disease? And from the few studies that have been published, the IgG is a better one because it lasts longer, but it comes on much later in the disease, starts about the 10th to 11th day. So the timing of the collection of the sample would also go a long way to determine what the sensitivity and the specificity is. And when we ask for samples here, we always tell them that they have to give us an idea of when the disease for the patient was diagnosed and when the patient actually got better. I don't know if that has answered the question.
The question, I don't know if Dr. Rotimi has anything to add on that. Dr. Rotimi, the question is on the use of antibody. Okay.
Yeah, I got the question. I don't think I have much to add to that. I think to some degree, we're probably a bit behind the US in the serology testing. That it's the only two platforms that has been formally approved here, which is the Roche and the Abbott that's platform. We are verifying the Siemens platform for the country here in Leeds, and we're doing that as we speak. But I think what she has said covers most of the questions. And actually, I did raise the point with the person who asked the question that I should clarify it a bit, but yeah, it wasn't that clear. But as been said, you want to go for the IgG test, and I think most of the platform now is for the IgG because that's what gives you a better indication of any long immunity, if there is any, and that is still to be established. Yes, so that's what I would say to that.
Okay, thank you very much. Well, the other question, I think some of these questions have kind of crossed. Somebody talked about validation and verification of IgG and IgM tests. So I think we've been able to talk about that. Those are the clinical utility of these antibody tests. We also have here a question on, which is also kind of antibody tests, in which there's a question here that is the CT value really representative of viral load for a swab? Can we have one of our resource persons give a response to that, please?
I guess that probably not Dr. Fotade can speak more on that, but from what I've gathered, no, it's not a direct representation of the viral load, but it does give an indication of the viral load. I think to do a form of viral load is more in the research context rather than in the diagnostic context. But as I said, I think given that Dr. Fotade does that directly, she may elaborate on that.
Yeah. Okay. Yeah, Dr. Fotade, maybe you'd be able to talk on that, and also the question that is asked, that are we able to do the viral load in Nigeria?
Okay, just to
if you can, I would also want you to talk on the question asked that the NCDC laid down any guidelines for setting up of EOC in states, or were states left to do as deemed convenient? I don't know if you can answer that because that's more of a policy question, not science. So, but if you can, please.
Okay, for the CT value,
questions then.
Just to agree with Dr. Rotimi that it's not a direct reflection. However, you could at least give an index of the level of the viral load that you have in a patient. Like, you know that the higher the CT value, then the lower the viral load, and then the reverse for when you have a low CT value. However, for you to be able to determine the viral load by itself, you need to have a standard. You need to plot a standard curve with a control organism, a control SARS-CoV-2 virus, and then correlate that with the plot, your own amplification plot, and then use that to determine what exactly is the value that you could say is the viral load. Whether if it's from stool sample, then it has to be how many copies do you have per microgram. If it's from swab, then you need to know how many copies do you have per microliter, and so on. But you need to do like a more qualitative real-time PCR for you to be able to detect the exact viral load. And at our lab in Ibadan, we are currently developing our in-house protocol for detecting the viral load for SARS-CoV-2. For the question on what RT-PCR platform do we use the Barat CFX96. And for the question on who determines who heads what pillar or what components makes up the emergency operations center, essentially is the function of the states, and the Nigerian Center for Disease Control does not dictate how many pillars an emergency operations center should have, or who specifically should head the emergency operations center. In Oyo State, we have our emergency operations center has a laboratory pillar, a case management pillar, a risk communication pillar, a logistics pillar, and a coordination pillar. And the laboratory pillar is headed by myself, and I'm also a member of the case management pillar. We also have an infection prevention and control pillar. And I know that in some states in Nigeria, like in Gombe, for instance, I know that a colleague is heading the IPC as well as the laboratory pillar for COVID-19 case response. So I think it depends on the state and what they want to do with their EOC.
Thank you very much. Well, before Dr. Akaba goes on, I know that there's a question that seems to have been repeated. Maybe the person didn't see that there was an answer given. Talking about testing, if the samples for routine other tests like hematology, chemistry are done in the same section. This had already been answered by Dr. Oladipo and Dr. Rutimi, that the testing is done in the micro lab, while the specimen prep is done in the level 2 and level 3 BSLs. But equipment are all in the same area. So the instruments are also used for other testing. So that's would answer that. So I would ask Dr. Akaba to quickly round up with his presentation, and then we probably will still have a few minutes and then be able to leave on time. Thank you.
Thank you, ma. I'm sorry to continue from where I stopped earlier on in respect to the presentation. I just briefly gave an overview of the challenges in terms of capacity, culture, attitude, and the risks of frictions. And I also talked about the benefits of quality management system in our practice, and also the objectives, talking about in terms of efficiency and effective laboratory practice, accurate testing, and reliability of the results. Also, now the next slide, I don't know if you can see my slide now. Hello? Hello? I don't know if you can see my slides.
We cannot see your slides, unfortunately.
Oh. So
it's okay, just go on.
Okay. The next aspect of the aspect is talking about what we can do as a next step in terms of improving our practices as laboratory physicians or pathologists. One of them is building competency, and which I think at this point in time, I need to give my mommy here, Dr. Mosu, the accolade, because over 3 weeks now, or more than 4 weeks, we've been working on the competency assessment tools that can be generally used in the country by a pathologist to enhance our practice. And I pray by God's grace, after the validation of the tool, it should be accepted. We should also tend to build conduct trainings in terms of management and execute strategies that at all levels that can enhance quality management implementation in our various practices as pathologists. We should also try to monitor the performance of the management system. This is where you talk about inviting an internal auditor into it, inviting somebody that has an experience. And the truth about it is that in my center, for instance, I'm talking particularly with my center, we have challenges in implementing quality management system because it has been polarized. There's sentiments, there's tribalism in terms of who is supposed to head is it from here? But quality management talks about integrity. You're talking about giving satisfaction back to your clients. You're talking about making your results to be acceptable globally. You're talking about standardizing the processes. You're talking about using your normative references of the 9001, 17025, and 1589, understanding the processes. But most times in this part of the world, we have challenges in implementing it because even our other colleagues, using the brain-to-brain phenomenon, the other colleagues in other specialty, they don't have the knowledge of quality management system. So we need to also create a room for advocacy. Dr. Oladipo made mention how CAP, where funds were released to the pathologists in the US through the influence of CAP. This was legislative advocacy, lobbying. Also, that's part of it. We need to make a policy statement so that people will understand the importance of quality management system in our practice in this part of the world. We need to also make sure we implement quality management training in our residents, even in the medical schools. I remember a program I attended in Abuja with Dr. Amosu and Professor Aisha Mama made mention that our institution or our facility, they've started a program on quality management system because it's not part of us in this part of the country. So these are the things we should look into. And so many other things we need to start thinking of. Trying to bridge the gap, talking about conducting a gap assessment of our procedure to detect risks and other things that we need to look at to make our practices robust so that we can stand and our results will be reliable and accepted globally. We also need to obtain accreditation. I don't know, I heard Dr. Fawata made mention of quality, external quality assurance. I don't know if the lab is ISO certified or has an accreditation, because I don't know for now if there's any lab in Nigeria or if we have a reference lab that we can use as a external quality assessment. I don't know for now, but if there's one, it's a good thing, and we need to key into it so that we can help our services. And also, as pathologists, we need to also implement the standard and use it daily in terms of management. The CAP algorithm shows that in terms of wave testing, you have to make sure you do your quality control twice. When in terms of non-wave testing, at least semi-annually. That was a presentation of one of the works that was written. I recall it was written by the former president. I don't know if she's the president of CAP, Godbe, Dr. Godbe, wrote something on that. And it's something we should also borrow, collaborate with other developed countries who have gone ahead and have implemented quality management and have improved laboratory services so that we can also improve our services. We should also inculcate this practice in our postgraduate resident training, not just coming like in Abuja. There was an experience, a fellow consultant made mention that when she was taught quality management system at by the National Postgraduate Medical Center, she never understood anything about it. That is now that it's becoming clearer when the College of Nigerian Pathologists brought out a program on quality management system organized by NINAS in collaboration with CMP. And so those are the things we need to look at. In summary, I wouldn't want to waste much time because this is more like an advocacy and a plea to all of us that are pathologists that we should inculcate the habit quality management system of quality management in our practice, because quality management system does not actually depend on title, it depends on qualification. And in summary, what I want us to take home is looking at these little words of mine. Competency assessment failure are the most common cited deficiency. Training and competency assessment are related, but they are different. We all say we do training, but training and competency assessment are different. Competency assessment is critical to optimal performance in the laboratory. Best practices include proper plan with areas of assessment method, schedule, and corrective actions. Thorough and accuracy record will help your laboratory. What is not appropriately documented is not done. Not even what is not documented is not done. What is not appropriately documented, it's not done. So I believe with this presentation of mine, I've been able to pontificate the minds of many people that have bias, or many colleagues of mine that have bias in quality management, so that we can improve our practice. Thank you.
Very much, Dr. Akaba. So please, we still have some minutes. We can do questions. We'll just try to round up quickly. Dr. Fawata, there's a question asking that, is there a national plan for EQA for the SARS-CoV-2 assay?
Well, I do know that the ministerial committee is just trying to bring that on at the moment. And I was only privy to the information because Professor Bakari is a member of the committee. But at the moment, I don't think they've started. But I know it's one of the action plan for the ministerial committee for COVID-19 response.
Thank you very much. I think basically some of the comments, some of them were more observations or comments.
Dr. Amusu, I would like to say something based on some of the questions I see here. And that's the fact that over here in the US, the bench work and the testing and everything is actually done by laboratory medical technologists or medical scientists. But because there are laws and because there's a hierarchy, they know that even by doing the tests, they need a pathologist to look at those results and to vet those results. And it's actually the pathologist that will tell them what exactly to do and how to go about it. And so that puts you, and even when the technologists are looking for information, they end up going to the College of American Pathologists website. So I think one of the ways to go about this back home in Nigeria is that we have to be the resource. We have to be the go-to resource for everybody when it comes to information that has to do with pathology and has to do with lab testing. And they should know that if they go to the College of Nigerian Pathologists website, that's where they're going to get the information that they need. I think that's one way we can start.
Thank you very much, Dr. Ladipo. Dr. Rotimi, do you have any questions or last minutes that you want to address?
Which one? Sorry.
No, I think most of the questions, or I mean, the questions seem to have been essentially covered. But probably should.
One that said I will answer live. So it's concerning the viral load. What's the relationship between the symptomatology and viral load? That's something I spoke about in the seminar last week. And maybe just for the benefit of those that are here, I think what is emerging with the pathophysiology of COVID-19 is that, yes, the viral load definitely is central to how the patients turn out. So the higher the viral load, because just as a quick recap, there are three kind of pathogenetic pathways now that seems to be emerging. One is that the possible direct cytopathic effect by the virus. The other is a dysregulated immune response state, which is so-called cytokine storm that you will have seen in papers. And associated with that is the lymphopenia. And the third is the tendency to thrombosis, which is slightly macroangiopathic. And all of those have the signature of the viruses in them. So the viral load yes, is related to symptomatology and the severity of the disease. In fact, I was presenting this to some of our trainees here yesterday, and one of them shared an experience that she did a postmortem on in a young patient, which is very uncommon in the UK to die from the disease. That patient did a CPR on his dad who collapsed at home and did mouth to mouth. And he quickly developed severe COVID and died from it. So this viral load is central to the outcome of the disease. And I think related to that question is, can we objectively say that asymptomatic patient transmits this infection? And I think the unequivocal answer to that is a yes. And this is what is called the silent spreaders, that yes, asymptomatic patients do transmit the disease, which is why all the social distancing and hand hygiene and all of that is important because you do not know who has it. Because for one reason that somebody may be handling the virus and therefore asymptomatic, another person may be a proper culture media for the virus to grow. So yes, and then the third question by the same person was between the nasopharyngeal and oropharyngeal, which gives a better yield. That's a catch-22 question, but I think from our experience in Leeds, the nasal swabs give more result because it's easier to take. Because the oral one is really not a comfortable sample to collect. And the context that, say in the UK, they send you the swab, you do it yourself. I don't see many people sticking that, putting the stick in their throat and collecting a good sample. So the fact that the nasal may give better yield is not necessarily that the nose has more viruses. It may just reflect the collection and the quality of the collection. But because it's easier, I think the nasal swab probably give a better yield.
Okay. Well, thank you very much. But just maybe a bit to that, what you just said is because there's already a question here that asks what quality control measures are actually available for the PCR tests, especially with respect to sample collection. So I guess that's, like he says, or she, that to be able to determine that the samples were actually properly collected. So how can we QC the sample collection itself?
Yeah, what we kind of done here is to some degree standardize the collection. So if people are trained to do the collection, and therefore we created all this drive-through, and I have had mine done, and they do a good job on your nose and throat, honestly. So with that, they get experience with it, and I think for the ones people will do themselves, it depends on how much fear they have of the disease. So doing them by trained people will give a better result, and that's one way to standardize it. But actually, my challenge to Nigeria and to the pathologists in Nigeria is, I think we should look into how you can do alternative samples. I'll go to the Ladipo and comment on that. I know that in the state of New Jersey, they've been using saliva, which they piloted alongside with their nasopharyngeal swab, and discovered that the saliva gives as good a result as the nasopharyngeal swab. And it's much easier to give a spit than to have a stick in your throat. And I think maybe that's something Dr. Fowotade can look into in Ibadan, that if you do a parallel testing of saliva and the nasopharyngeal swab and see if you get as good a result from the saliva, you probably have patients being more cooperative with that.
We tried to do that in my hospital here, and it wasn't very successful just because not all the PCR tests are the same and their sensitivities are different. So it depends on the level of sensitivity of the test that is being done, because the yield in saliva is actually lower than that of the nasopharyngeal swab. So that's the reason we haven't really adopted it in my hospital here. So it's always good to do a study to be able to find out if it's actually useful before going head on to collect such samples. So that would be a very good idea, and I agree with Dr. Rotimi.
Yeah, thank you very much. Well, we don't want to, we've already overshot our time by about 6 minutes, so we would make sure we round up within the next 4 minutes. Dr. Paba, there's a question here, if you can answer it, that says that, is there any reason, do you think there's any reason why there's yet to be a positive case in Cross River State? Are they doing something right that we all need to follow?
I'll say why we've not had any case in Cross River say for now is because we are not really sure on the sincerity aspect of the government if samples that were sent for patients suspected of COVID-19 were sent to the NDDC for this. And also we cannot validate the sample collection processes because it only comes from the state government. There's a strict regulation, and so we are just handicapped presently in Cross River State. So I would say we just believe by faith that it's not there. But for now, there's no testing going on in Cross River State.
Thank you very much. Dr. Paul, please, do you have any last minute comments?
Well, just to say that I also believe that there's a need to ramp up testing in Nigeria. I believe that even though we are not where we were when we started, but there's still need for a lot more centers to spring up and be able to build up capacity for testing for COVID-19. And I also saw some questions about the fact that we have gene experts available in some centers in Nigeria, and why is it that this has not been utilized for ramping up COVID-19 testing? I know that when you look at the NCDC strategy for COVID-19 testing, the plan is that as we move from the containment stage to the acceleration phase, there would be need to ramp up more testing, and then there will be need to add additional lines of testing aside the RT-PCR. And the gene expert is one of the tests that is being considered. And I know that presently we have about 6,000 cartridges of gene experts that have been imported into the country and are meant to be distributed to the various centers where they have gene expert capacity. However, the plan is to leverage on existing MDR TB centers that are known to have the necessary biosafety containment to be able to analyze these samples. However, again, the drawback that we have at the moment is that just like what we had for the serology kit test, this again is being planned to be handled by the Medical Lab Scientists Council of Nigeria. And one would wonder how well they would be able to handle this, considering the fact that we know that the testing for the serology rapid diagnostic test did not go well and was handled by the Medical Lab Science Council. And so if there's a way the College of Nigerian Pathologists could wade in at this point and ensure that pathologists come into the picture for ourselves and for our country.
Okay. Well, thank you very much. I actually also wanted to just pass a comment on the gene expert, because I think last year at the annual conference, the annual scientific conference for pathology, for the College of Nigerian Pathologists, we actually were able to get CEFI to sponsor. And the beauty was they came in and told us about everything we could use the gene expert for. Hoping that we said, okay, when we all go back to our facilities, we should start using it for some of those things, although that was just in November. Probably if we had started using it and started trying to, in those centers where they had left it just for TB testing, if we had started taking some degree of ownership, using it for our cancer diagnosis and all, it would be easy for us to, leverage. But I don't think it's all lost now. I think we can still show the relevance, and probably we'll just still see how we can also get CEFI to leverage on the fact that they had also given us some degree of sponsorship, or we can see what can be done about it. The president of the College of Nigerian Pathologists, Professor Olatunji, is also here. So in order to, as we round up, we'll ask him to also give us his comments and some
Thank you very much.
words of faith.
Thank you very much. And I'd like to appreciate our speakers this afternoon. Nice to see Jumoke again, at least from afar off, after a long time. I thank you for coming and for joining us. I have listened to Dr. Rutimi. This is not the first time, and I want to say, and also for what I did, I'm now an expert at listening to these people, and I just hope that I'm learning more and more. The College of Nigerian Pathologists, we understand the situation that we are in. I believe that these are strategic issues, and we are looking at them strategically. We have already written to the NCDC and offered our services to the NCDC. We have got a reply that says that we should expect them to call us. But we're also studying the situations, we are listening, we are seeing publications, we are seeing press briefings. We intend to respond to all this in a very in a strategic manner. I believe that some corrections are needed, even at the level of the federal ministry itself, because once the person who is advising belongs to one side and has an interest, then it's very difficult to stop it. But we are working very hard and we will not stop working. I want to thank you because this is part of what we ought to be doing. And I want to thank Tiliwa and Akim for putting this together. I'm glad to see Kingsley once again. It's one of our very hopes for a long time. You know, as some of us go off, we are happy that people like him will join us. Thank you very much, Abike, for what you are doing. At least they stock you in there. Just make sure that you are in there. Even if other people are shut out, at least you are inside. Just do what you can to do the job of the pathologist. And we will just go on until the proper recognition is given to us. Once again, I want to thank you very much for doing this and for inviting me to make these comments. Thank you very much.
Thank you very much, sir. Thank you very much. I want to especially thank again our resource persons, Dr. Jumoke Oladipo, Dr. Olondari, Dr. Diola Fawotade, and Dr. Kingsley Akaba. Thank you very much for the presentations, and please be sure that we're actually going to put some of these things together. It's not just presenting and letting the matter go off. We want to actually see how we can strengthen and create a niche for what we are doing in Nigeria. There will be no CME points for this webinar, but going further, like we said, it will be a series of engagements, and then we probably will be able to work out how we can have CME points. Participants will also receive an email after this to be able to assess. We'll have a survey just to be able to see the perception and if how well this has been received, and going further to be able to know what else we need to discuss. I want to thank Dr. Lawal very much for the hard work that he has put to get this together. And you can be sure that, like we said, you probably will get more and more invitations for webinars or meetings like this. But at the same time, please, if you find that there is a topic or there is something that you think you would also want to share or get people to know, not only pathologists, but even outside the pathology field, this will also provide a forum that you'll be able to get that your presentations across. So we thank you very much. We apologize that we've taken 15 minutes extra. Next time we'll make sure we do not take more time. We'll try and keep to the set time. So thank you all, and have a very good evening.
Thank you very much. Bye, everyone.
Bye-bye, ma.
Thank you, sir. Thank you. Thank you.
You're doing a good job, Dr. Fowotade.
Thank you, sir. Thank you very much, sir.
All right, thank you, everybody. We'll allow you to log out so that we can close caption the recording.